Today's presentation is going to cover the Gonstead approach and protocol to caring for patients with Facet syndrome and spondylolisthesis. Take a few minutes to read this case scenario. We'll be using this case to answer a series of questions in the lecture presentation. Facet syndrome, also known as facet pain. Facet syndrome consists of a patient presentation, a clinical presentation, and can be accompanied by radiological findings, as we'll discover today. Facet syndrome is a condition when the facets become very irritated and very sensitive. This can occur in a couple of ways. This graphic just shows a brief kind of graphic of what angry facet might look like. Facet syndrome can have referred pain patterns. This is not necessarily a neurological or nerve root presentation or radiating pain, but more of a trigger point area that can extend away from the spine in the area around the facets. The Facet syndrome presentation is not exclusive to the lumbar spine. It also can be found in the cervical spine. And here's a graphic representing some of the pain patterns for the referred pain for Facet syndrome in the cervical spine. The reason the lumbar spine and cervical spine are prone to Facet syndrome is because of the nature of the lordotic curve. Going into like the extension position with the anterior curve can leave the facets open to Facet syndrome. The thoracic spine, which is protected well by the rib cage and has a kyphosis, is really not a place where we find Facet syndrome very often, if at all. Facet signs and symptoms. Okay. Apologize for the noise there with the transition if you can hear them. Symptoms. Hip and buttock pain. This is a diffuse, achy, stiff, tight, and sore pain. It's not a neurological sharp shooting pain, but a more diffuse, achy type pain. You can often have cramping in the leg, primarily above the knee, kind of in the areas of the referred pain pattern areas. Not seen too often, but can happen with the Facet syndrome patient. They have lower back stiffness, especially in the morning or with inactivity. So if they've been sitting for a long period of time, when they transition to standing is when those facets then get, you feel the pain. They're in discomfort. And we'll discuss the reasons why in a minute. Typically absence of paresthesia, because it's not typically a pain that's generated from the nerve root, but more from the, obviously, facet joints. The physical signs. We have local paraspinal tenderness, often the case in many lower back issues, but again, tenderness in the soft tissue because of the paraspinal muscles guarding this area. Pain and hyperextension of the lumbar spine. Hyperextension or extension puts the lumbar spine in a position where it loads the facets, puts the facets into a compact situation, and because they're already feeling some discomfort and pain, the extension or hyperextension will exacerbate that pain. Absence of neurological deficit. Again, this is not typically a nerve root issue, or it's not a nerve root issue. So the neurological deficits, the neural package, usually does not have any positive findings. And we can have hip and buttock pain or back pain on the SLR. Doesn't mean that the straight leg raiser is positive, but it may have pain in other areas of the body when we bring that leg up. So it's not a positive SLR, but it does can have a positive finding in that we have lower back or buttock pain. An absence of nerve root tension signs. Like it said a few items before this, we don't see signs that show that the nerve root is being compromised. Okay, my apologies for the transitions on this slide, but I'm going to try to get them all out of the way here. So, picture of the x-ray on the left is a typical presentation of a patient with Facet syndrome. What we see here is the lumbar vertebrae, this one, in this case, L5, is in an extension position. What it does is it narrows the disc at the posterior aspect and opens up the disc at the anterior aspect. And what it does is it transfers the weight bearing or load bearing from the disc to the facets. That's not a good scenario for the facets because facets were made to guide motion, not to be load bearing parts of our anatomy. So when this happens, it makes the facets very sore, very angry, and usually leads to premature degenerative changes. Also, the tissues around that area, they can contract because now they're not moving through the normal range of motion, and it holds the position of the vertebrae here. So what do we do to correct this? Okay, we're going to use our normal P to A and I to S adjustment thrust in accordance with the facet angle, and then that P to A and I to S is going to be to open up the facets, because remember, these facets are now compacted. We want to open up those facets. And then once we drive P to A and I to S, we're going to turn that adjustment angle down through the disc plane line. So we're going to take care of the P to A and I to S, and then S to I through the disc plane line. And because this is a facet syndrome patient, when I begin adjusting them, I'm really going to put a little more emphasis on my I to S to open those facets before I drive through the disc plane line. And this patient is adjusted inside posture, because I want to open up those facets so I could put him inside posture. I could bring the leg up to help assist in opening the L5 facet joints. So when I make the adjustment, I can do this line of correction without putting them into too much or more extension as if they were on the knee chest. That just wouldn't be the proper way to adjust this right away. Okay. The good thing about facet syndrome patients with Gonstead care, with these type of adjustments, with this P to A and I to S, opening up those facets and then driving through the disc plane line, is they usually have improved motion and their pain presentation has subsided in 3 to 5 visits, which is a pretty good amount of time to take care of a particular issue. That 3 to 5 visits is anywhere between 2 and 3 weeks to get those visits in, because I do not see this patient every day. This patient's seen maybe 2 to 3 times a week. Just last quarter, I had a patient who had facet syndrome, almost this identical presentation. Although she was only able to come in once a week, even with once a week care, by the 3rd week, after the 3rd adjustment, she was pain-free, which was very good. Took care of her for months afterwards. We only had one more other day in those couple months of care that she had a little bit of an exacerbation of the facet syndrome, and she did very well. Part of the reason this patient did very well is, we'll get to the 3rd item here. I'm going to backtrack a little bit. The subluxation, even though the pain presentation is done in 3 to 5 visits, the subluxation will take 8 to 12 for us to get the full correction. So remind your patients, educate them, and let them know that, even though they're out of their pain presentation, the correction process is still not completed. And what helped my patient do so well with her care is, one, she was getting good adjustments, of course, by me. Who else, right? And I gave her a series of exercises, and she followed them to the T. These patients are giving exercises to reduce extension loading. These are core exercises, flexion exercises, anything we can do to get them to open up those facets with exercise and support the anterior core, because in the facet syndrome presentation like this, there may be an increase in lordosis pushing them into that extension position with the lumbar spine or the pelvis. We want to make sure that the pelvis stays in its normal position, good strong abdominal area, but also good core in general, and stretching exercises to stretch and open up these facets, because remember, they're contracted and so is the capsule, and we want to make sure that we give the patient these exercises. It will definitely enhance the care, how well they get out of their pain presentation, but also how well they maintain this condition once you got them in the corrective or past the corrective stage. Again, I apologize for those transitions if you can hear them. Okay, what we have here are 2 X-ray pictures here. The one on the left demonstrates the positioning of the lumbar spine for facet syndrome, and the one on the right demonstrates the positioning for the vertebrae for the acute lower back. With the Facet syndrome, the red lines here indicate the end plates. You can see that the vertebrae is stuck in an extension position, narrowing the disc at the posterior aspect. Typically, we also see some facet irritation or facet sclerosis because of this. It's reactive sclerosis because, again, those facets are being loaded up. They're not made to bear weight, so they will start early degenerative changes. The disc on the right is our classic D1 swollen disc. There is one difference with this patient and between this patient and the patient with the vertebrae stuck in extension. We could still improve the motion here, and they still do pretty much show improvement in pain in 3 to 5 visits. Their correction may take a little longer because we have less disc space. They're a little older typically. That disc will never regain its height, so we'll be battling keeping them symptom free and keeping the motion in that area as normal as we would like it to be. And even though we get the joint open up in the motion there, because the disc is degenerated, they're going to experience probably their Facet syndrome symptoms more often. So this is a patient who probably requires more intensive care during their corrective phase or even after that, because this is something we can't fully correct. Although they respond pretty quickly, this is something or condition that we'll have to stay working on probably quite a bit on this patient. And I tell the patients that right away to kind of give them an idea of what the prognosis is. The prognosis is good. We could probably get you out of pain pretty quickly, but this is something we've got to stay on top of, because if we don't, your symptomatology is liable to come back because of that disc. Now we are switching gears to spondylolisthesis. Here are 2 pictures demonstrating spondylolisthesis. Both of these happen to be spondylitic spondylos and just demonstrating the anterior slippage, which you are already familiar with. But we're going to learn how to care for these patients. Even though they have a spondylo, we could still have a very positive effect on their care and relieve their nerve pressure. So as I was saying, most often than not, the patients are unaware that they have this condition. I've cared for a few Olympic athletes who did not know that they had pars fractures until I took their x-ray to deliver care to them. And one of them did have lower back issues. The other one had nothing going on in the lower back, didn't have any symptomatology whatsoever, but had a grade 2 spondylo, and it did not affect their performance. They are one of the U.S.'s best athletes, if not the best athlete in their particular sport, and didn't even know they had it, never inhibited them. Symptoms of spondylolisthesis. Like I was saying on the previous slide, many of these people present with their spondylolisthesis and they have no symptoms. They're not presenting for the spondylolisthesis. It's often an incidental finding on the x-ray because they don't have symptoms. They don't have anything that the presentation tells us. They have a spondylo until we take the film. We're going to learn how to see the physical signs on the examination that could indicate a spondylo. Okay, these patients particularly are sore pain in the lower back. It's not the sharp electric pain, but it's a sore pain in the back, especially after exercise. This is where the spondylolisthesis patients differ from the Facet syndrome patients. The Facet syndrome patients typically have increase in their pain after being stationary for a period of time, and the spondylo patients typically have an increase in their pain after exercise or after a lot of movement. They have an increased lordosis. Imagine we have anterior slippage of that vertebrae pulling that lumbar spine and the weight bearing forward anterior to the pelvis. And when that happens, we also can have increased in lordosis, which we'll see here. Hamstring tightness and lumbar muscle spasms. Lordosis, tighter hamstring, because as there's anterior slippage of the lumbar vertebrae, tends to bring the pelvis along with it, puts the pelvis into a flexion position. When that happens, it lengthens the distance for the hamstrings because it lifts the ischial tuberosity, so we have tight hamstrings. Oftentimes the patient can have decreased pain or weakness in one or both legs. And here it says reduced ability to control bowel and bladder functions. I could honestly say I have never had a patient who had lost bowel or bladder functions because of their spondylo. then that starts approaching the Arcata equina syndrome, and I just really don't see that with spondylo patients. The lumbar muscle spasms kind of go with the increased lordosis. The muscles in the lower lumbar spine can contract, and they would contribute to that lordosis. And similar to the Facet syndrome patient, this patient is unlikely to have paresthesia or radicular pain. Suspecting a spondylolisthesis at L5 or even L4, but we're going to talk about L5 in this case. I think this is one of the coolest things for suspecting or detecting a spondylo before you even take the x-ray. And I have done this numerous times in practice, and it really does hold true that we have our lumbar spine. The patient presents with the hyperlordotic posture, okay, and then we take the film and we notice that motion palpation is restricted at L5. The reason your motion is restricted at L5, normally in class I would ask the class why, is because L5 is no longer attached to the vertebrae. So as you're putting it through its motion, flexion, extension, lateral flexion, rotation, the spine can move, but the spinous process is basically just being supported by the soft tissue around there. It may not move at all. Actually, when you're doing this examination, not only will the spinous not move, but you may feel the spinous has migrated posteriorly. So when you just examine the patient with your visualization, again, remember visualization has to be done without the gown, with the gown on. You can't see through it, through the clothes. So you have the gown open and you look at the patient's lumbar spine, and you notice that that spinous process in the lower lumbar spine sits posterior compared to the other ones. That may be an indication that there is a pars fracture because the spinous has migrated posteriorly. Okay. So besides that, even when you put this patient into the extension position in the lumbar spine, because now that the lumbar spinous process is not attached to the vertebrae, as you drive those facets together in extension, what it will do is it'll push the spinous process posteriorly because it's not attached anymore. So you can do Mopal on your patient, you push them, put them into extension, and then you feel the L5 spinous process want to push back against your finger. And normally it would kind of dip away, but it can actually push back against your finger. That's another indication of suspecting a spondylo at that vertebrae. And as it says here, there's more, you could palpate the spinous better or easier because it's migrated posteriorly. And also there might be a lot of edema either above or below it or both. What you see here is a visualization of your patient's back and spine, and just as I described on the earlier slide, the diagram or the arrows on this picture show the spinous process with a green arrow where it looks very prominent, and the blue arrows are showing where edema can exist above and below that spinous process. This is a classic presentation of a patient with a spondylo. I see this very often with these cases, especially if they've had a recent injury and this is an acute spondylo situation. You will see this almost 100% of the time. If the spinous isn't pushing posteriorly, you'll see edema around there because the spondylo, especially if it's spondylitic spondylo, is a bone fracture, as you know. So they'll have edema or swelling around that area and it'll present like this. This could also be the presentation of somebody with a chronic, well, it becomes chronic once it occurs, but because now that area is irritated, that spinous process is no longer attached, the ligaments around there stay kind of irritated till either it calms down because it's adapted to that position, the spinous has migrated to a place where the body feels comfortable with it, and on the very, very rare occasion, that edema and swelling can go away completely. In the Gonstead technique, we do have a protocol for taking care of our patients with spondylolisthesis. Okay, here's an image that we saw earlier with a spondylitic spondylo, grade 1, almost grade 2 here. And this patient, the correction is made in the side posture position, and it's delivered to the segment below the spondylo for a grade 1 and grade 2 spondylo. This patient is adjusted side posture on the segment below. We treat this almost like a BP since this picture represents the lowest lumbar. We'll deliver the adjustment to the segment below, and we must go through the disc plane line here. This is for grades 1 and 2. this scenario changes a little bit. So what you see here is the green line will indicate the segment that we're adjusting. Then we're going to adjust the segment below. So we want to push the segment back up to the disc, and we have to follow the disc plane line to do that. So it's P to A and S to I, just like we do for BP sacrum in this case. You can have spondylos up higher in the spine. So if there was a spondylo at L4, then we would contact L5 and push that P to A and through the disc plane line of the L4, L5 disc, whatever it may be. What we see here is a very big spondylo that has migrated the spinous very much posteriorly. You can see the L5 spinous is significantly posterior to the L4 spinous process. And you can see that the L5 spinous process, the vertebral body has migrated to a full-on grade 2 spondylo. That's a pretty big one there. So what do you do with this patient? So how do we correct this patient? Pretty extensive grade, like I said, beyond grade 2 spondylo, grade 3 and grade 4. This patient's adjusted differently. For the grade 3 and 4 spondylo, this patient is adjusted prone on the high-low table with the thoracic section or pelvis section locked. The reason we need that section locked is so we can protect the spondylo. What we'll do is we'll put this patient prone on the high-low table. We'll crank up the pelvis piece so we make sure that it stabilizes the pelvis. Also brings the sacrum up a little bit for us so we can make a good contact. And we contact S2 tubercle and drive this sacrum P to A and S to I. And you can see here it has a pretty darn steep disc plane line for that. So we make sure that we drive through it. This arrow is not in the right position. I apologize. That arrow should be pointing at the sacrum and going through the disc plane line there. So grades 1 and 2 are adjusted inside posture, the segment below. Grades 3 and 4 are adjusted on the high-low on the segment below. And if we're putting them high-low, the pelvis or thoracic piece stays locked to protect the spondylo. This picture here demonstrates a patient with possibly more than one spondylo. We could definitely see at the L3 vertebrae that it has slipped forward a little bit. This is a degenerative spondylo. You can see the disc at L3 is slightly narrower than the ones above and below. L4 looks pretty good. L5 has a very degenerated disc. So in this case, if L3 was the spondylo presentation, even though it's very mild, but it does exist, and we found a subluxation at L3, in this case I would contact L4, the segment below it, and push that one P to A to try to get back under that disc. I would not contact L3 to push P to A. So this would be an L4 adjustment. And because it's only a grade 1, more than likely side posture. Let's take this one step further in complexity. We have a very obvious degenerative spondylo at L4. And if we look at L5, it does have a slight anterior slippage on sacrum, again with a degenerative spondylo presentation. So if you found a subluxation and nerve pressure at L4 in this patient, which segment would you be adjusting? Well, we can't adjust L4, we know that, but are we going to adjust L5 or are we going to adjust sacrum on this patient? That's a clinical decision you're going to have to make at the time when the patient comes in. That L5 spondylo, it's a degenerative spondylo, so I am sure it's pretty stable. We're not going to push it off the edge per se. Or we're going to go all the way down to sacrum and adjust sacrum P to A to push that whole L5 sacrum complex back underneath 4. This decision will come after you have some experience, and I can't even give you the correct answer yet because I haven't felt the motion on this patient. I don't know their full presentation, and I haven't adjusted them yet. So if I choose to adjust L5 and the patient says, yeah, it was a little bit better, adjust them a couple more times at L5, said, doc, yeah, I'm getting better, but just not over the hump, I may go down to sacrum and adjust that, see if I can get the foundation set a little better for L5. And then the patient might say, okay, hey, whatever you did, I feel a lot better now. So you may have to experiment a little bit based on your knowledge, based on the patient's presentation, and based on how they're reacting to your adjusting. So if you're not getting what you need just from adjusting the L5 or just the sacrum, you may want to move up or down a segment to see how the patient responds. And of course, if they respond unfavorably, you may need to go back to what you're doing when you started. It just presents a more complex situation. We'll go right through this slide. It's just asking the questions in the discussion that we just had. What would you do with this patient? Would this be a patient that you take into your office or refer out right away? As you can tell, this is an MRI. This is not an X-ray. But you might say, oh my goodness, this patient needs to go directly to the ER. They need surgery. Well, there's a very similar case in the Plogger, the Purple Book, the textbook of clinical chiropractic, a specific chiropractic approach. There's a patient that presented to the Gonstead Clinic almost identical to this. They had the L5 vertebrae fused to the anterior part of sacrum. And you're thinking, oh my goodness, how'd they even walk in the clinic like that? We believe, or they believe, that this was a congenital anomaly of the patient. And the nervous system, the spinal cord, or the nerve roots in the lumbar and sacral area just figure out where they needed to be and go as this patient was growing and developing, or if it happened at such a young age, they adapted perfectly to the situation. So patient can present like this. It would be a very unusual, very odd thing, but how would you adjust this patient? You can't adjust L5. Could you adjust sacrum in this case? Or are you adjusting L4? It would create quite a dilemma for you, but I just wanted to show you that these conditions do exist and that all of them are not traumatic. Sometimes you get a very funky congenital anomaly. This case here is a very severe case. It was a traumatic case where the L5 and sacrum were sheared on each other, creating a humongous spondylo. The good thing about this one is that this patient, they were able to fuse them and stabilize them with very little to no neurological deficit in this case. So this patient was very fortunate that they were able to recover. That's not always the case, and thank goodness there is such a thing as spinal fusion surgery, because without it, this patient definitely would have had compromised nervous system and would have prevented or inhibited their ability to walk in the future. So surgery, when appropriate, is a good thing. As chiropractors, we try to benefit our patients so they can avoid these in the non-traumatic situations. And the more I speak with surgeons, especially neurosurgeons, the more they agree that, hey, try your chiropractic option first, because once you get surgery and they do particular fusion like this, there's no going back. Obviously, this case needed a surgical intervention. Sorry, went a little bit backwards there. But which one of these pictures represents the patient with Facet syndrome? If you take a look at these quickly, you can see, hopefully you're guessing or choosing the answer of B, because that is the one with the vertebrae stuck in an extension position. I don't know if you guys can see the results from a previous class that 29% of the class did not get this one correct, which is a little upsetting because the picture on the left is the exact two pictures I showed earlier in the presentation. The one on the left is the acute lower back D1 disc, and of course the one on the right is the vertebrae stuck in extension, representing Facet syndrome. What we have here is a case presentation. This is actually a case of mine that I took care of about 3 or 4 years back. This patient was a 57-year-old male. He's approximately 5'10" and weighed approximately between 250 and 270 pounds. So he's a big, thick guy. His chief complaint was pain in his left leg down into his foot. And he had an altered gait. He kind of limped on the left leg. The reason he limped on the left leg is because he lost some of his motor function for his plantar flexion. So he really couldn't push off on his left foot. So he walked with a gait that represented that. And I confirmed that with orthopedic tests on him. He had been under chiropractic care on the West Coast for a short period of time, and they referred him to me through the Gonstead referral system, and they sent him to me. They sent him with his x-rays. So he gave me the presentation. This is probably the gist of it. He didn't have a whole lot to say, but those are the particulars. He did have motor function loss on plantar flexion. His sensory was fine, and he had pain, like sciatic pain, but that pain was most prevalent in the foot itself. So it wasn't as strong in the sciatic area, but it was very strong pain in the foot. And these are the x-rays that he presented with. These are x-rays that he came to the clinic with, taken by a previous chiropractor. And when you look at these, you're thinking, oh my goodness, what am I going to do with this guy? He is completely overcome with arthritis in the lumbar spine. But what you may notice on the picture on the left-hand side, you'll notice these little circular artifacts all across the abdomen, almost in a rectangular type shape around the abdomen. You may or may not have a guess of what this might be, but since we can't answer live, you know what? I might just keep this case for lecture so I could explain the case and get some feedback from you guys. So you got the case scenario, you have the case here with the x-rays. I want you to look at that artifact, try to predict what it might be. And then what we'll do in lecture is I will go through this case very specifically so we have question and answers. What we have here are the things you should know from this lecture, the takeaway information. I left a little meat on the bone because I want you to tune into the lecture presentation on Friday. So I will not go through this presentation verbatim. I will probably cover the case at the very beginning, and I will certainly cover the case at the end, and I'll answer any questions in between. The lecture will probably be on the briefer side, but tune in to get some background and info on these cases. These cases, or cases like these, typically show up on examination, so tune in for those, but don't go away yet. What I have prepared for you, the next 3 slides are a little bit of a graphic here or a chart here that show you the differences between the acute lower back facet syndrome presentation and the spondylo presentation on patient presentation, your typical exam findings, your chiropractic findings, what adjustments are typically used, what's the management, and what's the approximate healing times for each of these cases. So for a quick study guide when preparing for the exam, these next 3 slides, the first one here is acute lower back, the next one is facet syndrome, and the last one is the spondylo, okay? What this does is it gives you a comparison for all 3 so you can see the differences or similarities if there are any, and it's a quick study guide to kind of outline the differences and different cares for these type of cases. Okay, have a good week, and I will see you on Friday.